Wait 5 seconds and then we can start. We have quorum. Okay.
So welcome and thank you for joining us today for the meeting of the New York City Health and Hospitals Board of Directors. Today's meeting is officially called to order. Please note for the record, Scott French is representing Stephen Banks and Philip Waddle representing Deputy Mayor Melanie Herzog, all in a voting capacity. Next on the agenda is the adoption of the minutes for the board meeting held January 28th, 2021. Are there any questions, comments, or suggested changes? So may I have a motion to approve the minutes?
So moved.
So I'm gonna poll all the board members separately. So Dr. Katz,
Yes.
Dr. Calamia,
Yes.
Dr. Myla Harrison,
Yes.
and by the way, welcome to the board. Thank you for joining us today. Philip Waddell.
Yes.
Philip. Thank you. Scott French.
Yes.
Barbara Lowe. Barbara. Okay, Robert Nolan.
Yes.
He's here.
I wish I moved.
Sally Hernandez Piñero. Sally. Sally. Okay, Sally. Frida Wang.
Yes.
Fenioski Peña Mora.
Yes.
Anita Kawatra.
Yes.
Thank you. So the minutes are adopted. During the executive session, the board received and approved oral and written governing body submissions from NYCH and H. Lincoln and Gouverneur Nursing Facility. The board received and approved semi-annual governing body reports, written submissions from NYC Health and Hospitals Queens. Please be aware that the 2020-21 annual public meetings for each borough have been rescheduled. All the meetings will convene at 6 p.m. and a determination will be made at a later date to whether they will be in person or virtual. And the date, so that you know, is Staten Island is Tuesday, March 16th, Manhattan, Tuesday, April 20th, Queens, Tuesday, May 25th, the Bronx is Tuesday, June 8th, and Brooklyn is Tuesday, June 15th. According to Article 6, Section C of the bylaws, appointment, the chair of the board shall annually appoint, with the approval of a majority of the board, members of the board to the standing committees. I would like to propose a motion to appoint Sally Hernandez Piñero as chair of the audit committee and a member of the community relations, equity, diversity and inclusion, and governance committees. Fenioski Peña Mora as chair of the equity, diversity and inclusion committee. Frida Wang as a member of the equity, diversity and inclusion committee, and Myla Harrison as member of the medical and professional affairs committee. Do I hear a second?
Second.
All in favor, please say yes.
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 Opposed, say no. Okay, so the appointments have been completed. VENDEC approvals. Since we began the process of approving contracts prior to VENDEC approvals, there is one item on today's agenda requiring VENDEC's approval, and those have the approval. There are 8 items from previous board meetings pending VENDEC's approval. Since we last met, we have received one VENDEC's approval. We will continue to notify the board as outstanding VENDEC's approvals are received. So we now move to the president's report. Dr. Katz.
Yes, I'm not going to read the whole part, although there are a couple of parts that I do want to read into the record. I want to start by talking about vaccine, because we all recognize that vaccine is how we get ourselves out of this pandemic. And the news about vaccine continues to be exceedingly good, despite what I think is some unhelpful fear-mongering around the variants. I think it's fine to talk about them. I don't think it's fine to call them scariants. I think that it has to be understood this is what viruses do when they're allowed to replicate, and that in general, the vaccines have been equally effective at preventing hospitalization and death, which is what we should care about. And I very much agree with people who point out that the coronavirus, COVID-19, is not going to disappear. That's not how viruses work. We will learn to live with the coronavirus. We will get ourselves vaccinated. We will achieve herd immunity. People will periodically get infected, but if they are vaccinated, they will not become hospitalized and they will not die, and therefore life will go on. What has made COVID so much a disruptor of everything about our life is that it kills people and it puts them in the hospital and it causes long-term side effects. When we talk about these vaccines, like for example, people have been worried about the fact that the new Johnson and Johnson vaccine has not had the same level of efficacy. What they're missing is that level of efficacy is based on the results of the nasal swabs. It is equally effective at preventing hospitalization and death, which again, that is what we care about. And the same with respect to the variants. The concern about the variants is just that we want to make sure that we vaccinate before the variants take hold in New York City. So I see it as a race to get the vaccine into people's arms and into their bodies before the variants are too widespread because they are more contagious. But I have full faith that the vaccines themselves will work. We may all need to get a booster at some point. That's unknown. The vaccines may need to be tweaked a little bit, to be more sensitive as the virus evolves. But really, when you consider that this virus has only been identified for a little bit more than a year, this is an amazing scientific success, and we should celebrate it. We should not be completely focused on the negative part. On the government affairs, I want to highlight the federal because we've gotten really key help from Senator Schumer, which gives me great pride. Senator Schumer was my assemblyman when I was growing up. He represented the area of South Bronx. My mom served on the PTA with his mom. And so I feel a very special Brooklyn connection to him. And he and his office has really helped us, along with Senator Gillibrand, on addressing an inadvertent problem that had previously caused by a federal medical assistance percentage enhancement that did not factor in the impact of the increase on disproportionate share hospital patients. And so because it didn't factor that in, and that was not intended, it was going to cost us quite a lot of money. And Leader Schumer, with Senator Gillibrand, has been very successful getting it into the House bill, and we look forward to being able to get those dollars. I also want to put into the record that I approved a declaration of emergency dated March 1st, 2020, which has subsequently updated and has been reissued through February 28th, 21 for the time period January 1, 2021 through January 31, 2021. The Office of Facilities Development issued 2 work orders to continue facility infrastructure updates supporting care for COVID-19 patients, and the system entered into 8 new emergency agreements, 2 hotel agreements for COVID-19 related quarantine services as part of the New York City Test and Trace program, 6 agreements with vendors to conduct extensive community outreach in New York City neighborhoods with high incidence of COVID-19, 2 of these 6 vendors are MWBE firms, and the other 4 all provided MWBE utilization plans. These agreements and work orders have a maximum authorized spend of $38,212,832. I, as always, appreciate your support, your questions, your suggestions on how H&H can be even better. Thank you.
Thank you, Dr. Katz. So let's, any questions from board members? Let me begin, Dr. Calamia.
Yeah, Mitch, so just a question as far as HHC's role in tracking and tracing these variants. Do we have such a role, and how does that actually take place?
So the lead agency is the Department of Health and Mental Hygiene, but because we have the brilliant Kenra Ford on our staff, we have been very active in working, getting them specimens, growing the number of specimens. There's widespread agreement that cities should be doing this kind of work. It has to be done locally because it's all about what are the variants that are circulating in your area. And as we're all learning, it's complicated. Not every variant is a bad variant, and not every genetic change is harmful. So trying to understand which ones are harmful, how they're affecting transmission is a local affair. And we've had, again, and I give Kenra a lot of credit, working with DOH-MH, we've very much expanded that testing over the last few weeks.
Thank you. Dr. Harrison? Any questions?
Not at this time. Thank you.
Okay. Philip? Wait. Philip?
Nothing for me, thank you.
Thank you. Scott?
Did you say Scott?
French?
No questions.
Thank you. Barbara? Lowe? Barbara? Oh. Okay. Robert Nolan? Bob Nolan?
If I may add a friendly amendment in Mitch's presentation, in order to try to show his continued enthusiasm for the South Bronx, he mentioned growing up in the South Bronx, which we know he
did I
didn't grow
say
up there.
South Bronx?
He really meant
South
Southern Brooklyn.
Yes, you
so
did.
that would be corrected.
I caught that too, Bob. That was my neighborhood as well. So, and it was
I saw the
definitely.
visa application, so that I know that the
Thank you.
locality is the southern part of Brooklyn, where my wife comes from. So if that could be changed,
Thank you, sir.
a friendly
Thank you.
amendment.
Thank you.
Okay. So, Ms. Lowe? Ms. Lowe? Go ahead.
Miss Lowe, we can hear you.
Problem here.
Miss Lowe?
Hello? Oh,
We hear you,
Yes.
Barbara.
Something happened.
She muted herself. Let's
Okay.
move on.
Okay, so, Sally Pinheiro?
I just wanted to thank you for the dental services update. And since it is an expanding area, I look forward to hearing more about it.
Yeah, thanks, Sally. I think we've been talking to Colicia. We want to plan a full review of the dental services, and we appreciate you raising it. And it's an area where I think we can do more. So let's do that.
Thank you.
Great, thank you. Frida Wang?
No questions. Thank you.
Thank you. Fenioski Peñamora, Dr. Peñamora?
Thank you, Mr. Chair. Dr. Cass, thank you for sharing that information, and particularly in terms of the vaccine, and of course, kind of framing for everybody to ensure that everybody feels that it is safe and it is contributing to the reduction that we see on the hospitalization. My question is more with respect to the role that Health and Hospital is having in the kind of the major vaccination centers like the Yankee Stadium. And, they have been opened up What is our role there, and how is that playing with the availability of the vaccine? We are opening all these major centers, but do we have the vaccines? And has those centers increased the number of people that we have been able to vaccinate through the H&H services?
Well, thanks for raising it, Fenny. So it is a bit confusing. Right now in New York City, there are 4 different operators of vaccine centers. There is health and hospitals. We are providing vaccinations at the 11 acute care hospitals, at our federally qualified health centers, and then we are running the mass vaccine centers in Bathgate, Bronx, and Brooklyn Army Terminal, Brooklyn. Those are ours. Then Department of Health and Mental Hygiene is running a variety of pop-up centers, and as well as some bricks and mortar centers. Then the state is running, I forgot we are also doing, I forgot City Field, where the Mets play. That's also ours. Sorry, I missed that one. So the big ones for us, Bathgate, Brooklyn Army Terminal, City Field. Then the state is operating with Somos at Yankee Stadium. And so that's a state run, not a city run. The state is also running Javits Center. And then, because that's not complicated enough, then there are FEMA centers that are run by the federal government in collaboration with the state. So, for example, Evans College in Brooklyn is being run as a FEMA center. The good thing is if you go to NYC Vaccine Finder, you will see all of them, all of the different sites, and people can click. The little bit of challenge that I've found in guiding my own patients is that some of them have specific zip codes. So it's not even the whole borough. So you have to know, and like the Yankee Stadium is only for people in the Bronx. City Field is only for people in Queens. So they all have, depending upon who their sponsor is, you have to sort of guide people to help find the vaccine. But the happy part on the finding the vaccine is I've noticed this week already is dramatically easier than 2 weeks ago. And I think 2 weeks from now is going to be dramatically easier than this. And I would predict by the end of March, we're going to completely change from a people are desperately trying to get a vaccine appointment to us desperately trying to get vaccine to people who haven't so far wanted to get vaccinated or who are just not, following the debate very much. And so it will move to more, how does health and hospitals better work to vaccinate people? One of the things we're doing that I'm very proud of is that we are giving vaccinations to our own patients on their visit. So yesterday I'm at Gouverneur. My first patient is a man over 80, monolingual Spanish speaker, right, who I do not think I would have ever successfully gotten either through the phone system or the online system, who, as soon as he arrived, my nurse took him down to Gouverneur. We reserved the site for him. He got vaccinated. He came up and had his visit with me, right? That's what we want to get to. We want to get to connecting the vaccine to good primary care, and that way the people are likely to listen to their own doctors if they're uncertain. And in fact, even I had told my nurse, as soon as he arrives, please take him to vaccination. And she texted me back, he wants to talk to you first. Which I think is very interesting. He had no contraindications to vaccination, and he wasn't hard to convince, but he wanted me to tell him. that he should get vaccinated. And so I had her put him in line. And then as soon as I got there, I went in line before the vaccine, and I told her, just tell him I'll be there. I went and met him. You should get vaccinated. And he said, yes, doctor. Well, actually, he said, see, doctor. And we were all set. So I think trying to that's where I want it to be, especially for health and hospitals. That really should be our role.
Thank you.
Thank you, Dr. Katz. And Anita Kawatra, any questions? Anita? Dr. Katz, so I have a question for you. So if we look at neighborhoods in the city, then since we have data coming from all these different sites, do we know in a given neighborhood how many people are vaccinated so that we know, going back to this example of what's going to happen a month from now, where we would know then, because some people come to our hospital, some people don't.
Right.
How do we know that we're reaching the people we need to reach?
So we do know the neighborhoods. Say DOHMH releases a report. It released it this week. I could ask Colicia help Colicia to find it. She's probably better than I am at finding it, but she'll circulate it to the board. This early report is a little bit off because among the first groups to get vaccinated were people related to employment. So you're vaccinating the police officers, the firefighters, the correction officers, the teachers, and they don't live evenly across the city. So, but that's mostly in the past. Most of those groups have gotten vaccinated, the most motivated people. So in the next weeks, I think the data is going to better reflect the city. And also, again, that's why it's so important for me to figure out how health and hospitals vaccinates our patients, because our patients are the ones who have borne this pandemic disproportionately and are less likely to get vaccinated because they're not on the websites, they're busy working hard days, right? They're running their families. So if we're doing it for our families, I think that the numbers will better reflect who really needs to be vaccinated. And again, if I'm right, by April, it won't be about shortage anymore. It'll all be about trying to get the vaccine. Johnson & Johnson, because that vaccine doesn't require refrigeration, offers some interesting opportunities for how you could do homebound people in a much easier way than you can with the current vaccinations. It's exciting.
It is. And I'm sure the board will be happy to hear more about this as it gets deployed and the progress we're making. Thank you so much.
Thank you.
Okay, so let me move on then. Go ahead. Somebody has a question? Or? Dr. Calamia, you have a question?
Yeah, it's just a couple of things, actually. One, you brought up a couple of important points, because it's so important for that patient at Gouverneur to be able to get that injection. In fact, the majority of vaccinations occur in the primary care doctor's office, followed probably by local pharmacies. So we've kind of disrupted that system. Do you see our being able, especially when Johnson & Johnson comes out, do we see our ability to start allowing or getting the patients to be able to be getting vaccines in their primary care sites? And one other quick question, just related to what we're doing when we are restricting to certain areas, whatever, to be able to be vaccinated. The only concern that really raised when I hear that is that going to deter some undocumented, perhaps, that there may be some issues with identifying residents? So those are my two questions for you.
Yeah. So let's do them in reverse order. I mean, obviously, we don't want to discourage people from coming. The rules, you have to show that you live in New York City, but we accept as proof a letter that you received at your address. So we don't, right? So all you need is for someone to mail you at an address. We don't require, you don't have to show a lease. Certainly you don't have to show any visas or but you are required to show a piece of mail that you received. So that's, whether, I think that still could discourage people, but I'd again say, I think by the end of March, it's not going to be an issue, right? Because again, it's an issue right now. There's been concern that some hospitals preferentially vaccinated suburban people, certain New York City hospitals, because they were trying to attract in patients who are more likely to be well insured. So that's why there was the addition of not a residency requirement in the sense of proving a lease, but at least a piece of mail. On the primary care, that is how it should be, and that's always how it's been. I think that the Johnson & Johnson will help because people of the normal refrigeration. I think at some point when it becomes more acceptable, when the supply is not so tight, the government, I believe, will stop worrying about first and second doses. That's been a very contentious area. And so we cannot use second doses as first doses or first doses as second doses, even though it's the same medication, right? There's zero difference. You say, well, what difference does that make? If you are, Dr. Calamia in practice, if you can do both from the same vial, you only have to open up one vial. One of the challenges we're having on this rule is that when we open a vial, we have 6 hours to use it. If it's a first dose, we always have waiting lists of people who want a first dose so far. So that's easy. Just call people on your waiting list for first dose. Second dose can be very challenging because everybody isn't eligible for a second dose. To get a second dose, you have to be the correct time, and it has to be the correct Pfizer versus Moderna. If your first dose was Moderna, I can't give you a second dose Pfizer. So I open up the same vial. I have 6 hours to use it or waste it. And I can only use it for second doses, of which I can't use a waiting list because I can only find people. What we actually do is we look for people who are due to get the second dose the next day, right? Because they're allowed to come a day earlier. But again, this is all based on shortage mentality, right? As soon as we move out of shortage mentality, people will say, sure, just keep track. Is it for them a first dose or a second dose? It's the same medication, use the same vial. And I think then many doctors would be able to say, oh, I'll have at least 5 people come today for first or second doses, no problem. And I'll be able to open up the vials. So that's how I see it. Pharmacies next week. Most Rite Aids, Duane Reade's, Costco, and I believe one more we'll be having, all on our website.
Thank you. Okay, so let's move to the resolution. So item number 2, Dr. Calamia, read the resolution.
Sure. Authorizing the New York City Health and Hospitals Corporation, the system, to sign a 5-year contract with Surgical Solutions, LLC, the vendor, for technician support for laparoscopic and endoscopic procedures, scope management, reprocessing, and consultative support, with 2 one-year options to renew the contract, exercisable only by the system, and with the total cost of the contract over its full potential 7-year term in the amount of $50,551,595.55, with a 5% contingency of $2,527,579.78 for a not to exceed total $53,079,175.33. It was approved by the Medical and Professional Affairs Committee unanimously on February 8th, 2021 for presentation to the full board.
Thank you.
We're going to start with Chris Roker with the
Okay.
presentation.
Okay, thank you, everyone. Good afternoon. So I just wanted to thank Joe Wilson, Dr. Parikh, and Dr. Villanueva, and also all of the committee. In 2015, New York City Health and Hospitals entered into an agreement with Surgical Solutions to provide for procedural technicians support for laparoscopic and endoscopic procedures. Currently, they support all of the acute care locations. The cost is based on a fee per procedure. The fee per procedure includes the technicianal support, the coverage for 24/7, the equipment leasing, repair, and disposables. Current program includes 76 dedicated on-site techs, management team who brings industry expertise and support with regulatory surveys. Surgical Solutions currently supports 50,000 laparoscopic and endoscopic cases annually. The contract expires this year, August 6th of 2021, and annualized spend with Surgical Solutions is $11,553,398.15. The overall procurement, we started in 2020. New York City Health and Hospitals issued out a RFP to procure a vendor who can provide procedural technicians to cover all laparoscopic and endoscopic procedures 24/7 for all of our sites, for all of the acute care hospitals. The vendor must possess knowledgeable management teams to provide guidance with infection prevention, capital planning, operational excellence, and continuing education for the technicians. The scope of the work, in scope, technicianal support for the laparoscopic and endoscopic procedures, scope management, reprocessing, consultative support. Out of scope, scope leasing, repair, and disposables. Cost structure moved from a fee per procedure based to a fixed monthly rate per technician. 4 suppliers responded who met the minimum requirements to the RFP: Prothel Healthcare, Olympus, Stryker, and Surgical Solutions. At the bottom here, you see we started the kickoff meeting in August. Then September, we went through CRC approval for the RFP. RFP was released, and then pre-bidders conference. October, proposal due. Proposal was reviewed. The due diligence by supply chain was done. References were checked. November, proposals were reviewed by the committee, and scoring was done. And then December, the supplier was awarded. So this is the new cost structure. So currently right now, we have Surgical Solutions. They do all the staffing, the equipment, maintenance, loaners, disposables. What we want to do is we want to decouple, right? And what we want to do is Surgical Solutions does the technical support, the scope management, reprocessing, and consultative support, which is $7,521,656.51 out of the $11,553,398.15, which leaves us the contracted supply, equipment, maintenance loaners, contracted suppliers, and disposables, which is the $4,031,741.64. This gives us greater buying power, purchasing power, as well as if we need to move equipment around and or buying new equipment. So it's a better way of doing our business. Next slide. This is the evaluation committee and how we scored it. It was on a 4 criteria. It was weighted, and then Surgical Solutions scored the highest. These are the makeup of our evaluation committee. So myself, physician advisor, perioperative services, GI, infection prevention, nursing, human resources, and finance. Next slide.
So Surgical Solutions is self-performing through its own employees 94% of the work under this agreement. They have committed the remaining 6%, $3.2 million to MWBE vendors. The way they'll accomplish that is using recruiting firms for all of their staff, which will be $700,000 over 7 years, and clinical advisory services, clinical education services, and operational advisory services, which will be $2.5 million over 7 years. And they too will be subcontracted through an MWBE. Next slide, please. And then also to share with the committee is the workforce diversity of Surgical Solutions. As you can see, their executives, managers, supervisors, their professionals, and their technicians, their workforce is dominated by female and minorities to make up the group of employees at Surgical Solutions. I'm going to have the next slide, Dr. Parikh, who is our surgeon lead, share the feedback of the current performance of Surgical Solutions.
So overall, the feedback has been, as far as the rating, has been good.
I can't hear.
Overall, the feedback has been good, as shown here on the slide, based on all of the descriptives sent to the facilities. And so the summaries at the bottom that their quality of their work has been very good.
Next slide.
So, board members, what we're asking for approval is supply chain is seeking approval to enter into the contract with Surgical Solutions for technical support, scope management, reprocessing, consultative support, terms for 5 years with 2 one-year options at sole discretion of New York City Health and Hospitals. Agreement will allow termination for convenience in part or whole by New York City Health and Hospitals. Total contract value is $50,551,595.55. 5% contingency, $2,527,579.78. Not to exceed $53,079,175.33. Thank you. Any questions?
Thank you. So any questions from board members? I'll start, Dr. Katz.
No questions.
Okay, thank you. Dr. Calamia?
No questions.
Thank you. Dr. Harrison?
No questions.
Thank you. Philip Waddell? Philip? Scott French? Any questions?
No questions.
Thank you. Barbara Lowe? Any questions?
No questions.
Thank you, Barbara. Robert Nolan?
No questions.
Thank you. Sally Hernandez Pinheiro?
Just quickly, you're retaining a component of the services that were originally provided by Surgical Solutions, and you indicate that you'll be able to realize some savings by retaining it. Were there efficiencies that were realized when all of the work was being done by Surgical Solutions, even though there may not have been cost savings involved? I'm just wondering whether, breaking off whatever it is, 40%, whether it's worth doing that.
So there's, go ahead, Joe.
My thought is that we procure our equipment and services for all of our other service lines, and we're able to extract a much better value from the vendors. So we believe that $4 million will be better served, and we'll actually gain newer equipment, better equipment with better service. So I think I think there's a scalability and an effectiveness in us doing the procurement in-house.
Okay, thank you.
Okay, Frida Juan, any questions?
Yeah, just following up on that, Joe, it was sort of a similar question. So I think, I actually think it makes sense, it sounds like, to break the two up. It seems to, because because a lot of this is equipment and sourcing of supplies, I assume that means you can actually get better pricing perhaps. And have you done any diligence on that? Like the $4 million, you expect that to be under that?
Absolutely. So over the past year, I have been working with the major manufacturers of scopes and electronic crawl stores, Olympus, Stryker, and Jacoby and North Central Bronx, who had joined the program last within the past couple of years. We had in supply chain had done all of the sourcing for those ORs as well as those GI areas. And I would believe that, you know, we've exercised a value of 20 to 30% where we were able to get more equipment to fulfill it and also have a better technology. And I would also say a better service plan, which I think is an important part of this, is when the owners of the equipment hold the contract for the service with the manufacturer, there's a greater accountability for uptime.
Great. And then I guess one concern that might occur then is the technicians are being provided by Surgical Solutions, right? So is there any danger that the equipment that we end up leasing and using is not something that their technicians are able to work with?
No, there's really 2 or 3 major manufacturers of the equipment which are represented today at Health and Hospital, so they're familiar with the equipment. And also in our new model, the equipment providers will also be having on-site education and service people to help guide Surgical Solutions and the H&H staff on the care of the equipment.
It sounds like a good plan. Thank you.
Thank you. Dr. Peñamora, any questions?
Thank you, Mr. Chair. I have 3 questions. One is that according to the estimate of the number of procedures and the amount of this contract, it looks like each procedure will be costing around $230. How is that compared to the previous contract? Did we realize any savings in the cost per procedure, or is about the same?
It's a little bit mixed because in the original Surgical Solutions agreement, the cost per procedure was different at each facility based on how many technicians were there, how much equipment was there, and what their volume was. So we had some facilities that may have been paying up near $500 per procedure for a laparoscopic, and some were as low as, you know, $110 for an endo. So I think this is going to give us greater price transparency with this. And also in the old model, when you're paying a fee per procedure, the busier you are paying for the equipment over and over. Here, as we become busier, we will enjoy that extra revenue.
Thank you. That's very helpful. The other question that I have is like, they are going to now in the new structure, they are going to provide the technician. I know that in certain contracts, the kind of the client or the owner reserves the right to approve the technicians. In this contract, do they have to submit the qualifications of the technicians and then you have an approval process, or is all to their discretion?
No, to be an OR tech in New York, you need to be CRCST certified. So there is a certification, and there is, you know, annual compliance that they need to go through and training to show that they have a certain skill level. And we do have a process with HR where this is documented. So we do have a robust process where these employees to make sure that they have the proper qualifications and that they have the continuing education. So as you had seen in the earlier slide, that we have a focus on education so their skills stay sharp and it's appropriately documented.
Thank you. And my third question is that I just wanted to commend you for sharing the data of the workforce diversity. I think that's very good, particularly in cases like these vendors that are not able to meet our MWB goals. At least we know that at least you're able to share their commitment overall to diversity in terms of their workforce. So I thank you, and I think those numbers look really good. I just have a question in terms of the structure that they are following to meet the goals that they committed. Based on what I read here, they have committed 6%. Can you walk us through how that was derived? Because you said that 95% is their own employees. And let me just finish all the questions so that maybe you answer all together. So that's one question, how that was derived. The second, I noticed that they are saying it seems that 6% and the areas that they feel that they will be able to gain some ability to hire MWBs is by using the recruiting firms that they use to recruit the technician. And so that will be a certain amount of dollars that will be allocated of that 6%. And the other one is the kind of the educational, clinical, and training services also to go to MWB. So the question is two-part there. First, how they arrive to the 6% and this 3.2 million. And second, are these the only two mechanisms that they are going to use to involve MWB?
Yeah, so the 94% is actually a pretty easy.
I apologize, cannot hear.
Yes, so the 94% number is quite easy now that we are in a just fee for model. So the 94% is the cost that is going to be paid by each facility for the use of the technician. So it's directly for the service and the labor. So the 6% is that extraneous number outside of the 94. So because it is such a self-performed, labor technician-driven agreement, we thought that the two key areas were the hiring of the technicians and the training of them. I don't believe I've seen a third opportunity, but it's something that, as we review their plans with OLA, we will continue to work to strive, to achieve and grow the number.
I just want to follow up on that question. But in the future state that you present in your slide, you have two parts. That is the technician, that is around 7.5 million. But then there is the 4 million for the contract supplier, equipment, disposable maintenance. Does that mean that will be our responsibility, health and hospital, to procure all those services? And do we have a plan for MWB for those services? And are these 3.2 accounting for both or only accounting for the technician cost of the 7.5?
Yeah, so the 3.2 is regarding, the surgical solutions portion of it. The $4 million is the responsibility of H&H to procure that equipment, supplies, and service. We are going to have to look at that as an opportunity. There are very few providers of laparoscopic and endoscopic equipment. There's only 3 major ones in the country. So that is Stryker, Karl Storz, and Olympus. So there may be limited opportunity, but as we progress this conversation in a different way, where we are going to have, a relationship directly between H&H and them, we will explore that absolutely and look for that opportunity.
Thank you. I would love to hear how that proceeds, because I think that will be an important component to ensure for this type of vendors that tends to be like really a good grip into the market to see how they can open up to ensure participation of MWB. So I would love to hear your progress on that. Thank you, Mr. Chair, for giving me the opportunity to ask the questions.
Thank you. Anita Kawatra, any questions? Anita? Okay, I have a quick question, which is like following up on what Fenioski asked. So for the second part, so do you have that contract line up? Because if you're hiring somebody to manage the process.
Yeah, so that $4 million for the equipment, we are actually going through clinical trials with the surgeons and the GIs to pick the best company, for their technology and service right now.
You're going through an RFP process for that, or how does that?
Well, because there are only 3 major ones, we're actually doing a negotiated acquisition. So we're trialing equipment and working with the peri-op committee and the GI committees for those decisions.
Okay, thank you. Okay, so let's have a, thank you so much. Let's have a vote. Let me just go quickly one by one. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Harrison?
Yes.
Philip Waddle? Mr. Waddle? Waddle, sorry. Scott French?
Yes.
Barbara Lowe?
Yes.
Robert Nolan?
Yes.
Sally Hernandez Piñero?
Yes.
Frida Wang?
Yes.
Benioski Peñamora?
Yes.
And Anita Kawatra? Okay, and Jose Pagan, yes.
I'm sorry,
So,
Jose, yes.
thank you, Anita. And so the resolution passes. Let's move to the next one. Dr. Peña Mora, you go next.
Thank you, Mr. Chair. Our resolution is authorizing the New York City Health and Hospitals Corporation, the system, to execute a customer installation commitment, CIC, with the New York City Department of Citywide Administrative Services, DCAS, and the New York Power Authority, NYPA, for an amount not to exceed $8,212,050, including a 10% contingency of $597,318 for the planning, design, procurement, construction management, and project management services necessary for energy efficiency upgrades, the project, and New York City Health and Hospital Queens, the facility. This was discussed at the Capital Committee on the 8th of February of 2021 and was approved to be passed along to the full board for consideration.
Good afternoon. My name is Christine Flaherty, Senior Vice President, Office of Facilities Development, and I'm joined by Oscar Gonzalez, Assistant Vice President, Capital Development Group. I thank you for your time to go through one of our many carbon reduction energy projects. To brief our board, since 2007, we have reduced our carbon intensity emissions by 32.86%, with a target of a 50% reduction by 2025. This is one of many projects that will fit into this goal. The project itself is at Queens Hospital. We're pursuing multiple energy efficiency projects under a program that aims to reduce our energy consumption as well as reduce our greenhouse gas. This program specifically addresses several efficiency measures that were discovered through an energy audit that are listed here: upgrading the boiler controls at 3 existing boilers, install chiller optimization controls, replacing 4 exterior pole-mounted wind solar hybrid lights, as well as 223 windows to be replaced along 6 floors of the N building, and pipe insulation, as well as installing heat pump hot water heaters for our N building for domestic hot water system. The next slide shows some visuals of the N building where all of the windows are going to be replaced, as well as the systems that are part of this energy upgrades. Just for context, the chiller plant upgrades are 20-year useful life, the exterior lighting 15 to 25 useful life, the windows themselves will have a useful life of 30 years, the piping 20 years, and the direct hot water system 20 to 25 years, as well as the boilers controls could range from 15 to 30 years. These projects are being funded both by DCAS 1 NYC capital dollars of $5.9 million, as well as our city capital dollars from Health and Hospitals at $2.2 million, with a total financing of $8,212,020. The project itself, through all of these various efficiency measures, will save us on energy annually $386,927, as well as savings in kilowatts and therms as indicated. This program is going to be executed with our partner New York Power Authority through the Encore 3 agreement that was executed and negotiated by DCAS and has ancillary agreements for us with ourselves, CUNY, DCAS, and Board of Ed. And that agreement is now in place as of January 1. The next slide. So this contract itself is procured through NYPA, utilizing and leveraging the design build contract with the New York City Public Works Investment Act. NYPA goes through a competitive process in collaboration with our facility and selected Guth DeCunzo as the construction manager for the project. And that construction manager competitively bids the body of the contract, the various projects listed here. Guth DeCunzo has received an 85% approval rating from NYPA, and they've completed over 230 projects for NYPA over time. The evaluation criteria looks at all elements of the firm's performance, and they also are the most cost-effective within the CM pool from NYPA. Since the time of our capital committee, we did meet with New York Power Authority, as Coons has been selected on a number of our projects to understand in greater detail the procurement and selection process. And NYPA has committed to partner with us on diversifying the pool of future firms just to ensure that Coons can do the great work here and at a number of our other sites, and that there's opportunity for multiple vendors that are on their pool. The subcontractor for this project includes Interstate Mechanical, Automated Logic, Able, Candela, as well as Whitestone Construction. The contracts itself do have a 30% MWBE goal that satisfies both the state and the city guidelines. Currently, this project is at a 15% MWBE utilization plan and is expected to increase to 71% pending MWBE certification of Whitestone Construction. Next slide, please. So this detailed slide shows you the utilization plan for the project. Whitestone Construction, which has a big portion of the project as the main prime doing the window replacement installation, they have submitted their certification for WBE, but that certification is pending. So at this time, we cannot commit the 71% that is anticipated for the MWBE utilization plan. The current plan as it stands is 15%, but we anticipate the 71%. The project itself is slated for a completion of December of 2022. This shows you a delineation of the total project budget, including construction, multiple soft costs, remediation, the professional services, contingency, design environmental, the construction management, and project management fees. The interest during construction that's listed here is a cap, and it's tied to reimbursement of the bills when NYPA submits their bill to us, because they do a forward pay into the job to get it started. That totals the project of $8.2 million. And the next slide is our resolution. We're ready and available to answer any additional questions, should the board have any.
Okay, any questions from board members? Dr. Katz? No. Dr. Calamia?
No questions.
Dr. Harrison?
No questions.
Philip Waddle? Scott French?
No questions.
Thank you. Barbara Lowe?
No questions.
Robert Nolan?
No questions.
Sally Hernandez Piñero?
Christine, the conditions that are being ameliorated here, I imagine, are common to many of our facilities. And I'm just wondering, the process or the criteria you used in selecting queens, is it a question of timing, or just curious to know how Queens was selected?
So we continue to do energy audits at all of our facilities. So giving a broader context, completed projects on our energy efficiency include work at Kings County, Woodhull, Kohler, many jobs at Kings County, as well as Lower Washington Heights. And then underway, we have work happening today at Woodhull, Lincoln, Cumberland, Coney Island, Elmhurst, Jacoby, and Bellevue. So this specific project is one that is in our list of pending and in the queue at Queens. But we also have pending in the queue more work at Bellevue, North Central Bronx, another project at Lincoln that I believe we presented the board, Metropolitan, as well as Harlem. So we are getting everywhere.
Okay.
We've had to prioritize, I think, based upon the size of our footprint and how much energy is being used. And so I think that's why our initial, more recent projects that were very large and completed were at Kings.
And do you what use is in the end building? What uses are in the building?
So I believe there's a large amount of administration, but I believe we also have a few clinical services. Based on the timing, we just hadn't had a Queens representative. I'm not sure if there's one on the call. I didn't have that in front of me.
Okay, thank you, Christine.
We can follow up for you to know. So.
Alrighty.
Thank you.
Thank
Frida Wang, any questions?
No, thank you, Christine, for providing the information on our carbon reductions. I think that's great. And are the projects that you just talked about with Sally, through the energy efficiency audit, that's kind of what's the result of our reductions, is that, or?
Yeah, that covers some of the recent. There was work previously as well, so we're happy to kind of share the full comprehensive list. But the work began in 2007 during the past mayor and has continued as we continue to work hard to reduce our carbon footprint.
Right, that's terrific. And the savings obviously is good as well, the financial savings. So thank you for following up on that.
Thank you.
Benioski, Peñamora, thank you.
Thank you, Mr. Chair. Christine and Oscar, thank you for your presentation, very thorough. I have 3 questions related to slides, the information presented in slide 5, 7, and 9. If we look at 5, I think if you calculate the payback, it's around 21 years. And when you were mentioning the life of the expected of the different systems, I don't recall, but was there any of them that were below 20 years, or all of them were above 20 years?
I think one of them ranged slightly, which had to do with the boiler controls themselves, and the range was very substantial, 15 to 30 years. So, as well as the exterior lighting, that was one that was 15 to 25.
But are there any other gains? Because, if we were to apply the payback period, we are in the border more or less in terms of the life of the different system. Are there other kind of benefits that I think you mentioned the carbon reduction, but are there other benefits that has been used to justify this investment?
Yes, well, in some cases, the systems themselves, like the windows, have to be replaced, and we also have carbon reduction. I'm going to let Oscar cover some of the details tied to the return, because there are some nuances in the calculation.
Hi, Dr. Peñamora, everybody. So some of the useful life went down.
I'm sorry, I can't hear you at all.
Can you hear me now?
Yes.
Yes, okay. So the payback went from 15 years to 21 years, which if it wasn't because of the windows, then that's what was, that's the reason why we included some of the, that's what increased, some of the savings. So that, let's see, I got a little lost here, sorry.
So the windows were added into this project because they have a substantial increase in the carbon reduction associated with the project, bringing the greenhouse gas levels down substantially. So the project's value and the symbol payback for the project would be 15 years if the windows were out of this project. However, the windows require replacement. We have greenhouse gas reductions that occur with them, and that brings the simple payback to 21 years across all of the different components.
Yeah, I just thinking like maybe as we, I know that you are interested, and I think something that we should do as a system to invest more in this type of projects, to present both kind of the payback period, but also the benefits, other benefits that sometimes are not as easy to quantify, so that to be able to get the full picture, because sometimes the financial payback may not provide the full picture. So that may be something of interest. I'm following up on this slide, and particularly when you go to slide 9, all the financing for these projects are coming from the city, either through DCAS or direct capital financing. But then in the budget, we have a line item of interest, I believe 3%, if I'm not mistaken. Can you elaborate of the rationale for that interest if all the funding is being provided by the city, and the city allocation process, I do not believe that has financing on it, but maybe this project has particularly unique characteristics.
So the uniqueness is that NIPA can you hear me? Can you hear me? Can you hear me now?
It's very difficult.
Can you hear me now?
Now, yes.
Okay, thank you. The NIPA Encore agreement is arranged where New York Power Authority initiates and does pre-work that they fund themselves, and at time of certain moments in time throughout the work order, we reimburse them.
Okay.
The interest that's listed here is the maximum amount of interest that could be incurred over the course of the entire life of the project. This is an annual amount, but it's capped. And so it's in our interest to both expedite the payments when they do come in to reduce our interest float, but this is just a budget line that the interest would not go any higher than this over the total project budget. So there is an element here where NIPA is paying forward in advance of certain of us reimbursing. And then we also similarly are submitting our CPs, submitting that to the city. And so there's a reimbursement process in multiple ways.
Thank you. I think this will be good. Like if more projects like this to kind of clarify the cash flow and why this interest line item adds up in terms of when the cost is paid by the provider, in this case NIPA, versus when the city reimburse them. So I think it will be good to ensure that that is presented. Now, if we go to slide 8, sorry about so many questions. No, actually, slide 7. Here, the utilization is 15% for the MWEs that have been already certified, and there is the expectation that another vendor will be certified. But if this vendor were not to be certified, what will be the path forward if this vendor is not certified, the one that will take the MWE percentage to 71%?
Well, the only path to increase the MWBE participation should these competitive procurements not meet the goals that we anticipate, would be if additional vendors are identified. Whitestone is manufacturing and installing the windows, and they competitively were selected. So which means their price is the lowest at this point. We do not have a second firm in the ready, if that's your question, to do the same work. We would have to ask NIPA that specific question, although I do know that they do take MWBE goals seriously. It was one of the topics when we met this month. And this is a WBE firm that has submitted their information to the state. So I hope that we would be able to give you a report out, in our next meeting or earlier when we do learn about their certification.
Thank you. And again, I don't think anybody will expect that they will have to go through the same vendor or same services, but definitely there are other areas that they could perhaps go and look for diversification of their subcontractors. So I just want to understand, and maybe having some those discussions. You never know what will happen. If this were not to occur, what will be the plan B to meet? And I believe the contract does have that requirement of the 30%. So they will have to find other ways to meet that. Is that correct?
Yes, there is a 30% goal for the contract.
Yeah, so there is no waiver in this case.
I'm not going to speak for NIPA, but I do not believe there is a waiver in place. We can confirm. I don't want to say something that I'm not 100% certain on, so I will confirm if there's a waiver.
Thank you. Thank you, Christine. Thank you, Oscar. Thank you, Mr. Chair.
Thank you. Anita Kawatra, do you have any questions?
Thank you.
Later. Okay, so let's have a vote then. Dr. Katz?
Yes.
Dr. Calamia?
Yes.
Dr. Harrison?
Yes.
Scott French?
Yes.
Barbara Lowe?
Yes.
Thank you. Robert Nolan?
Yes.
Sally Hernandez Piñero?
Yes.
Frida Wang?
Yes.
Manioski Peña Mora?
Yes.
And Anita Kawatra?
Yes.
And Jose Pagan, yes. So the resolution passes.
Thank you.
Thank you so much. So committee and subsidiary reports due to the virtual meeting setting, the committee and subsidiary reports were emailed to you for submission into the record. Are there any questions or comments about the reports? Is there any old or new business to come before this board? If there is no further business, I declare the NYC Health and Hospitals Corporation Board meeting adjourned. Thank you so much.
Thank you.
Thank you.
Thank you.
Bye, everybody.
Hi.
Take care.
Thank you,
Bye.
Calicia and David, for another successful virtual experience.
Thank
You.
you. Bye-bye.
I don't see anything on